Our second speaker is Alistair Hay. He's a professor of primary care at the School of Social and Community Medicine at the University of Bristol in the south of the UK. And his specific area of research is, among others, antimicrobial resistance. He has been a general practitioner, a real doctor, since 1997 and joined the academic unit of primary healthcare at Bristol in 2001, exactly 1 year before I visited Bristol to meet Matthias Egger at the Department of Social Medicine then. Also, Alistair teaches at the International Primary Care Leadership Program in Oxford. Let me say that this program is a very prestigious one, and it developed from the Brisbane Initiative, a collaboration of universities founded by a small group of heads of primary care departments many, many years ago. And they met in Brisbane 15 years ago, and I'm proud to say that I was part of that group. Alistair is actually running a highly interesting study together with Paul Little and others, which I find especially thrilling because it tackles an unresolved everyday problem in primary care, and the subject of this study is also the title of his talk, Oral Steroids for Acute Cough in Non-Asthmatic Adults, ? The OZAC trial.
Thank you very much, Michael. Guten Tag und vielen Dank für die Einladung zu sprechen. I'm afraid it doesn't get any better than that. And if my English was as good as your German, and if I could present my science in German as well as my European colleagues present their science in English, I would be very proud. So I'm very honoured. Thank you. So the University of Bristol and the city of Bristol is about 100 miles to the west of London. The city of Bristol has around 400,000 residents, and the university has around 30,000 students, and it's one of the highest ranked universities in the world. Michael's mentioned the School for Social and Community Medicine. We number around 800 staff, and within the school resides the Centre for Academic Primary Care, which has around 100 staff. And I'm privileged to lead the infection group within the Centre for Academic Primary Care, and this very talented group of scientists who represent a range of different disciplines, and that's where the real strength of the science arises, along with other collaborations. So the problem that we are interested in is antimicrobial resistance. And we know that primary care must make a contribution to the problem because we are the majority prescribers of antibiotics. And it's for that reason that we in the Centre for Academic Primary Care have developed these objectives in support of those, that problem. And we address we see the problem as one very much starting with the patient acquiring an infection on the left-hand side of the screen, and then, of course, transmitting that infection, and then the responsibility that we all have when we fall ill to self-care, and then, of course, the proportion of us who then choose to attend primary care and see our GP or nurse for the infection. And each of these points along the pathway is a potential target for research to reduce the overall use of antibiotics in primary care. Now, Paul Ehrlich, a German physician, of course, first mooted the idea of the magic bullet, which would be the sort of killer treatment that would stop the problem in its tracks. Unfortunately, I don't think that's the situation with antimicrobial resistance. Antimicrobial resistance is a complex problem. It's multifaceted. It's driven by antibiotics, but it's also driven by the transmission of resistant microbes. The microbes are incredibly fast to adapt to a changing environment. So any solution to antimicrobial resistance is going to need to approach the problem from all different directions to dissolve it away. And in my group, we've produced a number of different studies over the years to contribute to that evidence base, including, for example, this study in which we demonstrated the relative value of different antipyretics for children who were presenting to primary care unwell with fever. In the interest of time, I'm going to move on, because one of the objectives that you won't have had time to read there, and I didn't expect you to have time to read it, is that we want to develop and evaluate the clinical and cost effectiveness of interventions that may help reduce the severity of infections and may also be useful as alternatives to antibiotics. And that's where the OSAC trial, the oral steroids for acute cough trial, fits into this sort of plethora of potential solutions. So the rationale for this trial is that, of course, acute bronchitis, lower respiratory tract infections are extremely common, very familiar to all of us in primary care, and, of course, very expensive, both in terms of healthcare costs, but also in terms of societal costs for time away from work. And current management in majority of countries is still highly reliant on antibiotics, with the vast majority of patients still receiving antibiotics, despite good evidence that for the vast majority of those patients, antibiotics are actually not effective. And some of the work that we've done in the past has demonstrated that the routine use of antibiotics in primary care directly impacts on patients' individual risks of subsequent antimicrobial resistant infections, both in primary care, but also some early indicators that suggest that that risk may translate and transfer into their subsequent secondary care illness experience. So steroids are occasionally used in the UK for this sort of problem, and just talking very briefly to some of my German hosts this afternoon, I understand that you may also resort to either inhaled steroids or maybe even occasionally oral steroids for maybe patients who have been suffering more extreme symptoms with acute chest infections. Mark, who we've just heard from, was kind enough to run a secondary analysis of a study that he'd already published, in which he established that patients in the US, around 15% with acute chest infections, are currently being prescribed oral prednisolone. And current guidelines don't make any mention of whether steroids should be or shouldn't be used for this condition. Now, we thought hard about whether the potential role of corticosteroids for chest infections, and the rationale here is that there are, of course, a number of overlapping symptoms and also pathophysiology with asthma. So patients, of course, will experience wheeze and breathlessness in an acute chest infection, even though they don't have asthma, and it's therefore plausible, and we hypothesize that those patients might benefit from corticosteroids, and that in turn might be a useful alternative treatment. And not only that, but we know that patients with more severe lower respiratory infections, and particularly community-acquired pneumonias, patients who have been sufficiently unwell to reach hospital, do benefit from corticosteroids. So there was additional rationale for our hypothesis. And of course, we already know that there are other infections, such as croup, where children benefit from corticosteroids. So our primary objectives within this study were to see if we could demonstrate a 20% reduction in the duration of a moderately bad or worse cough, and or the severity of symptoms at days 2 to 4 with a 40 milligram 5-day course of oral prednisolone compared with placebo in adults who had presented to primary care with an acute chest infection. This was a randomized trial, a parallel design, clearly blinded, and a superiority hypothesis. and a multi-centre study with PIs in Oxford, Nottingham and Southampton, including Mike Moore here, who then collaborated to coordinate the recruitment of patients from GP practices in their areas. So we included adults over the age of 18 consulting with the main symptom of cough, which had lasted for no more than 28 days, and who had at least one symptom or sign that pointed to a lower respiratory tract infection. So chest pain, wheezing, sputum, or shortness of breath, all of which had to be within the last 24 hours. In the UK, we quite often use a delayed prescribing strategy. And so clinicians, if they were happy that the patient didn't need an immediate antibiotic, but could be given a delayed antibiotic, these patients were also eligible. We excluded patients who had known diagnoses of asthma or COPD, and we also, of course, excluded the patients who needed immediate antibiotic treatment, were very unwell, or needed to be admitted to hospital. And, of course, we excluded patients for whom steroids would be unsafe. So the intervention was 2 20-milligram prednisolone tablets taken once daily for 5 days with a matched placebo. And the primary outcomes were measured on a validated symptom diary score, which was measured or recorded by the parent each day for up to 28 days. On a Likert scale, with 0 being a normal or not affected for that particular symptom, up to 6 for that, where that symptom was rated as bad as it could be. And the primary outcomes then were the duration of a moderately bad or worse cough, so that's a score of at least 3. So the last day on which the patient scored their cough as being 3 or more. And the second primary outcome was the mean of their symptom severity scores for those symptoms that you see there on the right for days 2 to 4. So the mean on day 2, the mean on day 3, the mean on day 4, and then the mean of those means. The main outcome of those 2 primaries was considered to be the moderately bad or worse cough, and using data from a previous study of Mike and Paul Little's, where we knew that the average duration of moderately bad or worse cough was 5.8 days. We established that with an alpha of 0.05, we would need at least 174 patients in the analytic sample per arm to demonstrate a 20% reduction. With that number, we would also have 89% power and an alpha of 0.001 to detect a 20% reduction in the symptom severity. The statistical analysis followed a very standardized approach using an intention to treat basis with the Cox proportional model used for the moderately bad or worse cough duration and a linear regression model used for the symptom severity. I'll also present some data around the secondary outcomes, which included the duration of the moderately bad or worse symptoms, the duration until symptoms were fully resolved, adverse events, some data around patient satisfaction, some data around antibiotic consumption, and because we were concerned that there might be some patients who had crept into our sample who didn't have a label of asthma or COPD at baseline, but perhaps for whom treatment had revealed this diagnosis, we also looked at the number of those patients at 3 months. Finally, we did some pre-specified subgroup analyses using those criteria that you see in front of you there. And, for example, I think some people may ask at the end, were patients with a wheeze more likely to benefit from this sort of treatment? So this is exactly what this sort of subgroup analysis would look at. Or were patients who had a longer illness or who were older more likely to benefit? Okay, so moving on to results, we recruited to the number we needed. That, in my experience, is a pretty tall order and not something that happens with every trial. So we did randomize 401 patients, of whom 3 needed to be removed prior to analysis, and then our overall follow-up rates were very high. Symptom severity follow-up rates were over 90%. The moderately bad or worse cough was less in terms of our analytic sample, because not every patient actually had a moderately bad or worse cough at baseline. So I'm sure you're going to want to look at these characteristics fairly closely, because I think many of you will be wondering, is the sample in this trial similar to the sorts of patients that I see in my clinic with acute bronchitis? So you may want to just ask yourself that question while you cast your eye down this table. So around 40% of the patients were male. They were sort of a mean age of between 44 and 50, depending on which arm they were in. They were largely balanced, but the ones with asterisk were slightly imbalanced, and so we adjusted our analyses for those. Very majority white population, which is reflective of the UK. Around two-thirds were employed. Half were a current or a previous smoker. We said that asthma, we operationalized our definition of asthma as patients with a current label and anyone that had had any asthma medication within 5 years, so a fairly high bar. But you'll see there that there were 5% of our sample that had used asthma medications more than 5 years previously. The duration of illness prior to presentation was somewhere between 10 days and 2 weeks. And then you'll see the majority had reported productive cough or breathlessness within the last 24 hours. Nearly half had a wheeze. That's a patient-reported wheeze within 24 hours. And around half had chest pain within 24 hours. And then in terms of the clinical examination, you'll see there that the vital signs, as you would expect for this sort of population, were normal in the vast majority of these patients. Interestingly, the peak flow was abnormal in around 40%, and you'll see also that around 11 to 13% received a delayed antibiotic prescription. So, how did they get on in terms of taking the treatment? Well, over 90% fully completed the course in both arms, and we asked them to tell us which arm they thought they were in, to see if we could establish whether they had been unblinded, and we were satisfied that they hadn't been, because 50% correctly guessed the treatment, which is what we would expect by chance alone. So on to the main results. So the duration of moderately bad or worse cough. This is a Kaplan-Meier curve. So along the x-axis is time in days, and along the y-axis there is the proportion who have recovered. And you'll see there that just eyeballing that, it doesn't look like there's a great deal of difference between the treatment groups, between the placebo and the prednisolone. The mean duration was 6.5 days in the prednisolone group and just under 7.5 days in the placebo group. And when you subject that to the statistical analysis, there was no evidence of a treatment effect. And just to help in the interpretation, remembering that we thought that the 20% was the minimum important difference, we did an accelerated failure time analysis as well that spits out a percentage rather than a hazard ratio. And you'll see the reduction there is of the order of about 8%. And even the upper limit of the reduction is around 24%, so the vast majority of these patients are not meeting our 20% threshold for reduction. So that's the first of the two primary outcomes. The second then was the mean symptom score on days 2 to 4. And again, just eyeballing that graph, it doesn't look like there's a tremendous difference. The mean in the prednisolone group was just under 2 and just over 2 in the placebo group. And once again, when that's subjected to statistical analysis, we find no evidence of a difference for symptom severity between days 2 and 4. And again, just to go to that 20% reduction that we thought was the minimum difference that would be important, we're not meeting that threshold at all. So this is really quite strong evidence of no effect for symptom severity. Okay, so what about the individual symptoms on their own? The duration of the moderately bad or worse symptoms, we're seeing no evidence of any difference for all of those symptoms, bar phlegm. So productive cough, possibly, but you've got to interpret that with a little bit of caution because of multiple testing. You would expect 1 in 20 of these tests to come up significant by chance alone, and we're probably not far off that here. Although having said that, When you look at the total duration of symptoms, again, all of them, there are no evidence of any difference for any of the symptoms except for phlegm. So, again, could be a multiple testing effect, but it's curious that it is the same symptom twice, where there did appear to be some evidence of a treatment effect. We didn't observe any difference between the arms in adverse effects, neither expected nor unexpected adverse events. There were no serious adverse events observed, so no patient was admitted to hospital during the trial. There were no deaths, and there was no difference in the proportion of patients reconsulting. Patient satisfaction, so we asked the patients at 7 days, so that's 2 days after they've finished their treatment course, if they thought that their OSAC trial tablets had helped them feel better from their cough, and there was a bit of evidence to suggest that the prednisolone group felt that they had a higher rate of improvement than the placebo group. And that actually, interestingly, ties in and is consistent with the quality of life score as well, which shows a small but nonetheless significant improvement in quality of life. And for those of us who prescribe prednisolone, we probably recognize that there is a sort of overall well-being effect, a non-specific effect from steroids that this may be picking up. We also asked if patients would want to use these same tablets again, were they to experience the same illness again, and we found no difference between the prednisolone and placebo groups in response to that question. Neither did we find any difference in antibiotics consumed at 7 or 28 days between the treatment groups. And then finally, when we looked at the notes review for possible new diagnoses of asthma or COPD, we only found 3. I said finally. This is finally. The subgroup analyses, again, you have to interpret these with a bit of caution because they do tend to be a little bit underpowered, but we found no evidence of a differential treatment effect in any of these groups. So the presence of wheeze when the GPs listened into the patient's chests, that did not seem to influence the chances of the patients recovering any faster if they had prednisolone. The same was true for age, and the same was true for illness duration pre-randomization. And that was true for both the moderately bad or worse outcome and the symptom severity outcome. So I'm moving towards completion now. So in terms of the strengths of the study, we think this was a well-conducted, rigorous, randomized trial, the gold standard design for this sort of evaluation of a treatment. It was adequately powered. And it was done in the community, so that's good in terms of being the sorts of patients that primary care is dealing with. We don't like to hear the hospitals telling us about how treatments work there. We want to know how they're working with our patients. The one weakness that we did experience was this slightly higher than we had anticipated number of patients who didn't have a moderately bad or worse cough at baseline, but the results were robust to various sensitivity analyses that we conducted. So, in conclusion, the OSAC trial results seem to point quite strongly to to there not being an effect, a beneficial effect for prednisolone in patients in primary care who don't already have asthma or COPD but are presenting with acute bronchitis. And I think, and we think, that these data suggest that really oral prednisolone should not be used for this group of patients. Whether the results are likely to hold true for inhaled steroids, arguable. On the one hand, if a 40 milligram dose of prednisolone for 5 days doesn't prove effective, it seems unlikely that even a high dose inhaled corticosteroid would be effective, but some might wish to discuss that, and maybe there's room for further research there. And then the other point, guess, is were these patients sufficiently unwell? So if you think of acute bronchitis, the very mild end of the illness spectrum, there will be some very well patients with it. There'll be some moderately unwell patients with it that we still see in primary care. And then at the other end of the spectrum, we've got community-acquired pneumonia, and at the very end, community-acquired pneumonia for patients actually needing to be hospitalized. We know there are benefits in that group of patients who are really unwell. How far we crept up from the spectrum from the very mild end into the moderate end, I think is debatable. but there may still be some useful treatment effects for patients who are right in that middle. Not quite severe enough to need to go to hospital, not quite severe enough to meet the criteria for a community-acquired pneumonia, but have got a really severe acute bronchitis. And it may be that future research should focus on those, maybe with the help of CRP testing to identify them as perhaps a higher risk group. So many thanks for your attention, and my final slide is to acknowledge the very large number of people who are required to do a piece of research like this. As many of you will know, my thanks to them all, of course to Mike, who's in the audience here as well. Thank you. Should we do questions afterwards? Yeah. Fine.
I have a small question, Alistair, by the way. Jean Chenot made a meta-analysis of steroids with upper respiratory infections, published in the Annals. What was the result from that? Yeah. Even for the short term. Okay. Thank you, Alistair, for your interesting lecture.